So speaking of plasma, getting back to the real utility of plasma and liquid biopsies of identifying genetic aberrations that may be missed in tissue, we've come a long way in the past 5 years. You know, having liquid biopsy, the clinical utility, identifying T790M, but more recently looking at the role of layering in liquid at the time of the first treatment or before treatment in the treatment naive setting. Josh, you want to talk to us about some of the data we've seen recently about the role of liquid biopsies for treatment-naive patients in lung cancer?
Yeah, absolutely. So as you mentioned, liquid biopsy is really emerging as a good way to obtain molecular information. It is not 100% sensitive. The sensitivity is somewhere around 70 to 80% in most of the series, and it's thought to be a little bit lower for fusions. But the issue is that when you find something on a liquid biopsy, it is actionable. You can take it to the bank and do something with that. And as you were mentioning before, Ross, the turnaround is often faster, so there's a lot of benefits. One of the issues that many people have spoken to in the community as well as in academia have when you have a new diagnosis of lung cancer is not having enough tissue. So our group did a series led by my colleague, Dr. Agarwal, where we looked at tissue biopsies versus plasma biopsies. We found that a good portion of patients were not able to have enough tissue to do molecular profiling, and that's at a center where very good interventional pulmonologists, we pride ourselves on getting this information, and what they were able to show was that when you across molecular targets, not just EGFR, when you identify a target on a liquid biopsy, you can act on it, and the treatment response is similar to what you'd expect from a tissue-based.
And so based on that, and then we've got the Nile data too that's been recently published, showing essentially the same thing, that if you layer in liquid at the beginning, you're more likely to pick up on actionable mutations that can drive treatment decisions. Let's do another vote. I like the votes. Who uses liquid biopsy on every patient when they walk through the door?
Every
patient.
Let's do this. Who does
Can we say who thinks we should be using maybe as a first step? Because
as chair, I'll go with the question that I went with at the beginning.
There we go.
Who uses a liquid biopsy on all stage 4 lung cancer patients who have had a biopsy that have confirmed adenocarcinoma or where NGS is pending?
Yes, I mean, I don't know if all,
Pending or?
Pending. Don't know if you're going to have it or not.
I don't know if I'm going to have it or not.
It's been biopsied as CK7, TTF1 positive. It's been sent off to the in-house assay. You're waiting for the result. The patient's in your office. You're telling them, as you usually do, we've got about 2 to 3 weeks to wait here. Does everyone at that point use a liquid biopsy?
Okay. I mean, for me, it's the same. You know how kind of like you can do ALK-IHC? And it just gives you an answer in a relatively few days, or some people have a rapid EGFR test. And yet you're still sending off that big next generation sequencing panel. It's like that. You're kind of spreading your bets, so if you get a result back earlier, you can act on it.
Yeah, I think the most common situation that I use it, and it's very helpful, is a patient comes to me, they have insufficient or depleted tissue, and I know I'm going to have to order a new biopsy. So I'm ordering that biopsy at our institution. That's taking 7 to 10 days. I'm likely to get the ctDNA back that I'm drawing in the office that day. Before the biopsy happens, I can actually cancel the biopsy and remove any risk.
But do you cancel? Well,
I do. I cancel the biopsy. The NGS testing is already running. It's harder to cancel.
But I do that. The other setting which I've done it is if I have a second opinion, the patient had a biopsy at their local institution. I need to get the block. I have no idea what the block is going to look like or where things are, then I will do a liquid biopsy. But if something is internal and our pathologists have seen it, they say there is adequate tissue for molecular, then I don't do a liquid biopsy in that setting.
Go ahead.
I was just going to say, my perspective is that in an ideal world, I think absolutely, we should be sending both of these on this test. I really do believe the data that these can be complementary, and if you are able to send and get both, you're going to pick up more than if you send either or the other. I think, Ross, you brought up the issue of health economics, and I think that there is a concern here about insurance coverage and sending them off, and so that's been my hesitation. I would like to send it for everyone while the tissue is pending, but I want to kind of reserve that for the patients where I really feel like I need it, just in case there are any issues with coverage.
I tend to use it on just about everyone that has a biopsy done. Maybe if I know and the pathologist can ensure that there is adequate tissue, then maybe I'll hold off on an asymptomatic patient. But for patients in which there are second opinions, where the tissue block's in the nevosphere somewhere out there that I'm trying to track down, that's certainly an opportunity. And then we've learned from this data, from your data, from Agrawal's data, from Penn, we've learned from Nile, we're just not as good as we think we are at completing tissue genotyping. I mean, in the Nile data, less than, I believe, 25% of patients had completed biomarker testing for all targets, and that was under the umbrella of a clinical trial where they were mandating tissue and concording it with plasma. So, I think this is a discussion, I'm being somewhat controversial here just to kind of elicit discussions, but I don't think we're as good as we think we are, even in the halls of academic medicine, and I think, oftentimes we think we have enough tissue and then we don't. Health economics, I think, are a big deal. I think, can we make this cost effective for patients? And I think that will be important.
One thing that is helpful is that our pathologists in the pathology report will write, they'll say, this is the diagnosis, adenocarcinoma of the lung. They're like, there seems to be adequate tissue to do molecular testing, and we're going to do that.
Yeah.
And that's been very helpful. And they'll also write, this is not a big biopsy, right? Like there is scant tissue, we might be able to do it, and so that helps guide my decision making.
I want to pick up on one thing that Josh said, in the sense that everything you see on the blood-based thing, you can believe you can take to the bank. I would say with the exception of gene amplification. I do not believe that NGS in the blood really is a good way of calling gene amplification.
So you think that if you see gene amplification in the blood, you don't believe it?
No. I think it overcalls it because, first of all, it's kind of like, 1 plus 2 plus 3 plus. Like, what does that mean?
Right.
And it all depends on the bioinformatics, and it's a black box. And certainly we've had people have that called, and then you do FISH, and there's no amplification at all.
The other place where there is, it's not a false positive, but the other factor which needs to be discussed is CHIP, this clonal hematopoiesis of indeterminate potential. And this is when,
explain that?
Absolutely, I can explain that. So, you have blood, and inside the blood there's a plasma, there's DNA floating in the plasma, the cell-free DNA. But when we're doing this analysis, you can also get DNA from the white blood cells, the red blood cells, and they can get mutations. That's what MDS is. And so patients can have this clonal growth of mutated cells, and they can be identified with recurrent mutations. And some of those mutations are the same mutations that happen in cancer. So for instance, P53, pretty common mutation in both CHIP and in cancer. Luckily, for the purposes of our analyses, there is no CHIP mutation that is associated with a targetable alteration, which was true up until today, because one mutation that is seen in CHIP is KRAS.
It's rare, but you see it.
It's rare, and it can be seen. And so actually, the one thing that I will say is that if I have a patient who their liquid biopsy only comes back with KRAS, I have tended to regard that as a not informative assay, and I will repeat it with the tissue.
Are the same KRAS point mutations in CHIP as in lung cancer?
I'm not sure.
I'm not sure.
Yeah, I don't know if that was described, and Josh wrote a very nice editorial last year on this, looking at CHIP, and yeah, it is rare, but KRAS is there, and I think it changes our algorithm, because if we see a KRAS in the plasma, we could essentially say, you know what, it's probably in the tissue, it's not druggable, I don't even need to follow up on a tissue biopsy.
The person probably doesn't have EGFR or
But
anything
there is a rare chance that that is a CHIP mutation, and that the patient harbors a totally different alteration in the tissue, and that may have been missed. So
Do we get a clue from the percentage? I mean, is CHIP like 30% in the cfDNA?
It's so the percent. What the percentage can do is when I see that is I tend to think more of germline sort of changes. That's what but it's not as reliable because not all the cells are going to have. So you can still see it. I will say that the editorial that I wrote, the co-author on it, was also very good then. So
Did you just promote yourself?
Never said my name. Never prompted him to say that either.
I think the one other key point about plasma that I think is for most people something that we all know and accept, but always worth pointing out too, is that negative plasma results are another key limitation, right? Yeah. So if you send off the plasma test and you don't find anything, that does not mean that you can stop and that the patient does not have an actionable mutation. And I think that's always an important point to remember, because
not everybody sheds.
Exactly. You may have someone who is an EGFR patient or KRAS or anything and is just a non-shedder, and that plasma may come back negative. So I think that it's always really important in the face of a negative plasma test to still go back and do tissue testing.